Hey everybody, my name's Madison Barrett, and this is my drug category project over depression. Originally, I had signed up to cover anxiety and depression, but after talking with Dr. Wintersgill, there's just so many guidelines out there that cover both of them that she kind of wanted me to hone in on one. And so this is over depression, and it's also going to be focused on the general adult population. So the best practice guidelines are from the American Psychological Association and also from the Veterans Affairs and Department of Defense. Both of these guidelines come from them. A couple of important things to note about depression: it's extremely prevalent and one of the most common mood disorders among adults in the United States. So in 2014, 6.7% of the adult population in the United States reported at least one major depressive episode. So as future primary care providers, this is going to be a really important topic for us to be highly aware of. So first line drugs, for the initial treatment, you're going to be looking at either psychotherapy or pharmacotherapy with a second generation antidepressant. So the psychotherapy may include things like behavioral therapy, cognitive behavioral therapy, interpersonal psychotherapy, psychodynamic therapy, and supportive therapy. The second generation antidepressants to consider are going to be the SSRIs, the SNRIs, and both of the guidelines mentioned Wellbutrin, which is the bupropion as well. It's important to note that if treatment's not effective after 4 to 6 weeks, you want to consider alternate pharmacotherapy or maybe continue the pharmacotherapy and add on some psychotherapy. The second line drugs, these are drugs that if there is a partial or limited response to initial therapy, these things are going to want to be considered. So maybe we want to try a different medication listed from the first line therapies, maybe another SSRI or SNRI. But the main second line drugs listed in both of the guidelines are TCAs, MAOIs, esketamine, ketamine, and nifazodone. The esketamine and ketamine, those are both going to be after other drugs have been trialed and have not been effective. So you can also combine therapies and do a pharmacotherapy, a psychotherapy, and maybe add on an additional antidepressant. It all is patient specific. So for patients who who achieve remission with an antidepressant medication, both guidelines also recommend continuing the medication for about 6 months to decrease risk of relapse. The pharmacodynamics and pharmacotherapeutics of these drugs, the first line treatments with SSRIs, they're going to inhibit the reuptake of serotonin. SNRIs are going to inhibit the reuptake of serotonin and norepinephrine. The Wellbutrin is going to inhibit reuptake of dopamine and norepinephrine. For the second line treatments, TCAs are going to inhibit the reuptake of norepinephrine and serotonin at the presynaptic terminals. MAOIs are going to inhibit the monoamine oxidase enzyme that's responsible for catabolizing serotonin, norepinephrine, and dopamine. The esketamine and ketamine, their mechanism of action is not completely understood, but they're thought to work at the NMDA receptors by inhibiting glutamate release. And then the nifazodone is going to inhibit serotonin and norepinephrine reuptake. Implications on body systems. It's important to remember the black box warning for antidepressants that speaks to the increased risk for suicide or suicidal ideation. So that's definitely some major education you want to give your patients. So the SSRIs, some implications may be sexual dysfunction, weight gain, CNS stimulation, or serotonin syndrome. The SNRIs, nausea, diastolic hypertension, CNS stimulation. The TCAs, their toxicity is more likely to occur with this class than others, and that may include cardiovascular toxicity, CNS toxicity, anticholinergic toxicity, which could include refractory hypotension, ventricular arrhythmias, seizures, and coma. But in general, the implications for body systems is going to be sedation, orthostatic hypotension, and anticholinergic effects. And these are not recommended when a patient is already taking an MAOI. So for the MAOIs, a hypertensive crisis can occur when combined with foods that are high in tyramine, CNS stimulation, and hypotension, and you do not want to use an MAOI in a patient with severe renal impairment. These are some of the economic factors of depression. On the left side of the screen, you can see the number of patients that have been diagnosed with major depressive disorder has increased since 2010. The cost to treat these patients has not gone up very much, but there is a slight increase. And then the other graphs on the right side of the screen are kind of about the employment implications of patients that have been diagnosed with MDD. The special populations, it's important to remember that each of these have their own guidelines. So if you're taking care of adolescents or children, you're going to need to look up those specific guidelines. But in general, for adolescents, we can use psychotherapy or pharmacotherapy with fluoxetine. That seemed to be the drug that was mentioned in both guidelines for adolescents. The most in pregnant or breastfeeding patients, we're going to consider psychotherapy as first line treatment. But if a patient is struggling with postpartum depression, sertraline was the recommended drug, or other SSRIs. And then in adults over 65 years, psychotherapy alone or combined with a second generation antidepressant similar to the guidelines for the general adult population. So these are my references, and thank you so much.